In this video, we present a case of radiofrequency ablation as treatment for primary hyperparathyroidism due to an intrathyroidal parathyroid adenoma. The patient is a 48-year-old female with a 1-year history of hypercalcemia. Serum calcium level was 10.8 milligrams per deciliter with an elevated PTH level of 133 picograms per milliliter. TSH was normal at 0.49. The patient has a history of chronic renal insufficiency with a GFR of 54. Ultrasound imaging revealed a right intrathyroidal lesion measuring 0.8 by 0.6 by 0.5 centimeters for a volume of 0.12 centimeters cubed. Doppler flow was suspicious for a parathyroid adenoma. Biopsy with a 25 gauge needle had a PTH washout of 1,333 picograms per nanoliter. Given the patient's age and chronic renal insufficiency, she met criteria for surgical intervention and was referred to a high-volume head and neck surgeon. Due to the intrathyroidal location of the adenoma, the patient was offered a right hemothyroidectomy and parathyroidectomy, which this euthyroid patient refused. The patient was subsequently offered radiofrequency ablation, for which she provided consent. The patient was placed in the supine position with a hyperextended neck, and the target parathyroid adenoma and vital cervical structures were visualized with ultrasonography in real time. Here we can see vascular flow to the parathyroid adenoma as well as the carotid artery and jugular vein. Hydrodissection was performed using 2% lidocaine for local anesthesia. A 25 gauge needle is advanced towards the posterior medial aspect of the right inferior pole of the thyroid gland, aiming for the fibrous capsule of the thyroid. Subsequently, 5% cold D5W, 0 to 4 degrees centigrade, was used to hydrodissect the parathyroid adenoma away from the tracheoesophageal groove and to protect the recurrent laryngeal nerve. The electrode antenna with a 7 mm active tip was advanced into the node under ultrasound guidance using a transismic approach. Ablation was performed using 35 watts of power. A fixed ablation technique was used given the small size of the parathyroid adenoma and the inability to safely use a moving shot technique. Ablation can be seen by the hyperechoic changes within the target adenoma. The electrode was repositioned and a second ablation was performed to ensure that the adenoma was completely ablated. Again, the hyperechoic signaling on ultrasound can be seen during the ablation procedure. The patient's vital signs and voice were reassessed following the procedure. No hoarseness or other abnormality was noted. The patient used ibuprofen for discomfort and made an unremarkable recovery. Follow-up imaging at 2 months revealed that the parathyroid adenoma had now shrank to 0.7 by 0.4 by 0.4 centimeters, a volume of 0.08 centimeters cubed. This represents a reduction in size by 53%. Serum calcium is now normal at 9.2 milligrams per deciliter, and PTH is now 80 picograms per milliliter. TSH remains normal at 1.4. Further follow-up will be required, but we demonstrate the use of radiofrequency ablation for the normalization of calcium levels in a patient with primary hyperparathyroidism due to a right intrathyroidal parathyroid adenoma.